Hey guys, I had a few requests to go over ocular ultrasound and in particular retinal detachments in the last few weeks. So I put together a small presentation to go over the basics and to hopefully clarify some slight confusions. So optical ultrasound, as you know, is one of ACEP's principal ultrasound applications. So it's definitely within our purview to use and implement this strategy in the ER setting. The beauty of the eye is that it is comprised of humor or vitreous, which is very much composed of a water-like substance and allows us to utilize the best components of ultrasound to view our images, much like the bladder, as well as fluid-filled cysts and abscesses, which really allow us to get a good view of the structure we're looking at.
Number 1, 2, 3.
This is how you start doing an ocular ultrasound. I tried to get Mackenzie to model, but he was a bit bashful, so he wouldn't do this. Anyway, all you do is put a tegaderm on the eye. The beauty of using the tegaderm is, and you can tell this to your patients, is that it doesn't rip the eyebrows off, nor does it rip the eyelashes off. That's a question I've often had. You don't actually have to use it. The gel isn't corrosive to the eye at all. It doesn't. I've done this numerous times to myself, and you can actually forego using it. But it's a nice touch to use. It's easy to put on, easy to take off. It's tolerated very well. Here's using the probe on the eyeball, as you can see, sliding back and forth with your probe. The probe here is in a transverse orientation. You can absolutely put it in a longitudinal location as well. And I do suggest doing this when you're doing your exam. It gives you the best comprehensive look at the eyeball. Here's what a normal eyeball looks like. And again, this is the fanning back and forth. The patient's actually moving their eye left and right here in the video clip. This is a nice, pretty image. And then to translate it to what you're looking at with an ophthalmoscope, this is a normal retina and posterior aspect of the eyeball in a beautiful dilated optical exam, which I'm sure we're getting every time. A retinal detachment with this technology, or just using a standard ophthalmoscope, appears somewhat like this. Here's your attached retina here, here's your detached portion. As you can see, it's a lot lighter colored. It doesn't have this nice perfusion and redness and hue here. Again, here's another example. Here's the detachment here on the inferior aspect of your screen, and there's a slight tear in the retina. So here's the case that we can often get in the ER. 75-year-old, acute visual changes, possibly floaters. States it seems to be in one eye, but she's not really sure. Her past medical history is, like most of our patients, all-encompassing, and she obviously has risk factors. She may or may not have some dementia, and she's there by herself. This is a case we're all used to. So the question is whether we activate the stroke team. This is something we do fairly often in the ER, get our neurology colleagues involved. I would argue that in this case, this is a good opportunity to utilize your bedside ultrasound and at least rule out a large retinal detachment. Again, this isn't a 100% sensitivity test, but if you see something that suggests a retinal detachment, especially in the right setting, such as a patient with floaters or unilateral vision changes, it can be pretty helpful and help guide your therapy and avoid potentially large workups. So this is what we did. Put the ultrasound on the eyeball. And here you go. So taking a peek at the screen. So again, the probe is oriented right on top of a tegaderm. As you can see, the eyeball is very close to the surface, so it allows a great medium for the sonographic waves to pass through and to give you a good visualization of the eyeball itself. This is the eye moving back and forth, and as you can see here, there's something tethered right to the posterior aspect of the eye. The optic nerve shadow is actually right here, this dark shadow, and then attached to it, anchored right to that, is your retina. And as you can see, it's detached. It's actually detached on both sides, and it's looking, it's as if it's shaking back and forth as the eyeball moves. Here's another view, much like the previous. This is very classic for retinal detachments. As you see, it attaches to this posterior aspect of the eye. A vitreous hemorrhage, which I'll show you in a little bit, is different than this. It doesn't attach. It more appears diffusely scattered echogenic material. This is pretty constant and clear, whereas vitreous hemorrhage is going to be scattered bright white material throughout the globe. It's not going to have this nice linear appearance and tethered to the back of the globe. This is another example. This is a different patient. Here you can see it's just on one side. It doesn't have the bilateral aspect of the retinal detachment. The last one was a very big retinal detachment. This one is unilateral. As you can see, though, it's very apparent. It's hard to miss that. A normal globe, as we saw before, is just starkly anechoic, without any echogenic material within. Here's another example here. You can see it's attaching down here. This is actually going up on both sides. And just to give you a pictorial of what we're looking at, this is, if you flip this 90 degrees, this is at the bottom of your screen, and here's your detachment coming up here. And here's the break in the retina, detached retina, and this gives you unilateral eye symptoms and like a shade coming down. Again, the normal globe, this just shows you the difference. And here's your retinal detachment. So pretty clear, pretty clear. Lastly, I did mention that I wanted to show you the vitreous hemorrhage. As you can see here, it's almost like a washer machine of echogenic material flushing around. Again, this is going to be a little bit different of a patient presentation, possibly more along the line of floaters rather than a shade coming down. Again, though, patient complaints do vary. This patient did complain of just floaters, although she did have a retinal detachment. Either complaint should prompt you to grab your probe and put it on the eyeball in question and just make sure you don't see any flap coming from the posterior aspect of the eye, or in this case, washer machine-like material throughout the globe itself. Lastly, just a bonus. It's pretty cool. This is a consensual pupillary response. So the patient has constriction here of the pupil in the top left corner. The probe is on this eyeball. Light is shined in the other eyeball, and you can see constriction of the pupil itself, which is pretty neat. So the eye is an extremely accessible acoustic window. Utilize it freely and without any harm to the patient. I will say that you do not want to use it in globe trauma. That is a relative contraindication, or a ruptured globe, so please be careful with that. But for common eye complaints such as floaters and decreased vision, especially unilaterally, feel free to put the probe on and, of course, save your images. Let me know if you have any questions. Thanks, guys.